our second non-medical session. Thank you for joining us and thank you for bearing with us through some tech. Dr. Joe Gibbons is going to present today on severe asthma and new mechanisms. And Dr. Gibbons, I'll let you go ahead and get started and introduce yourself, so the floor is yours.
Thank you so much, and thank you everyone for having me today. Good afternoon. My name is Joe Gibbons. I'm a PharmD and a board-certified pharmacotherapy specialist. I work for Amgen as an asthma allergy medical science liaison, and I'll place my contact information in the chat after the presentation if anyone in the audience wants to reach out to discuss anything presented today, or in general, any scientific details surrounding asthma, the mechanisms surrounding it. Patient education and provider education is a huge passion of mine. So on the medical end, in my role, it's just really, fulfills everything I would want to be able to present on science to you, just like we're doing today. So thank you again for having me. Today, we're going to discuss the central role of the epithelium and how thymic stromal lymphopoietin alpha, or TSLP, plays an intricate role in severe asthma, immunology, and inflammation. And can everyone see my screen?
Yes, sir, we can see.
Perfect. So today, we're going to detail the burden of asthma, and at a high level, we're going to overview the inflammation drivers in this disease process. We will then get into understanding the epithelium and how TSLP plays a role in this broad heterogeneous disease. So let's talk about asthma. As we all know, it's a chronic inflammatory disease of the airways. This disease involves innate and adaptive cells of the immune system acting together with epithelial cells to cause 1, bronchial airway hyperreactivity, 2, mucus overproduction, and among other things, airway remodeling and airway narrowing. Symptomatically in the patient, these processes lead to shortness of breath, wheezing, and chest tightness. The heterogeneity of this disease involves multiple pathways. And because of those multiple pathways, it makes this difficult condition to treat as the disease progresses to severe asthma. A recent study showed that almost 60% of patients with severe asthma were either not controlled or suboptimally controlled. As we're all aware, oral corticosteroid therapy, or OCS, as I'll use moving forward, is used during acute exacerbations and potentially even chronically in more severe patients. Corticosteroids are associated with multiple side effects, and asthma exacerbations leading to hospitalizations are a huge cost burden on the healthcare system. These exacerbations annually occur in ranges of 12 to 27% of severe asthma patients, depending on the study analyzed. GINA guidelines. We're all extremely familiar with what's shown here. They overall outline treatment options for asthma patients, but we're not going to delve into the guidelines today. The main point for us is to discuss severe asthma and uncontrolled asthma. So severe asthma requires GINA step 4 or step 5 therapy. Treatment for this spectrum of patients includes medium to high dose inhaled corticosteroids, plus another controller, usually a long-acting beta agonist. Along with those controller medications, you have rescue inhalers, as we all know, which are either an ICS or inhaled corticosteroid or a short-acting beta agonist. Additionally, other options such as oral corticosteroids that we discussed or biologics may be considered. What is uncontrolled asthma? 20 to 50% of severe asthma patients have uncontrolled disease. Patients with uncontrolled asthma have a reduced quality of life, may use oral corticosteroids that can have those long-term side effects, and have an increased use of healthcare resource utilization that we previously discussed. Uncontrolled asthma is defined as either poor symptom control, greater than or equal to 2 exacerbations per year requiring oral corticosteroids, or greater than or equal to 1 exacerbation requiring hospitalization. Of severe asthma patients, up to 20% may have greater than or equal to 2 exacerbations per year, again, contributing to the cost of the healthcare system. Up to 50% of patients have poor symptom control based on the asthma control test. In 2014, the American Thoracic Society and the European Respiratory Society put out a position statement that defined uncontrolled asthma. It includes what we discussed on the previous slide and what is shown here. The main point overall is that severe uncontrolled asthma is a burden for patients and a burden and cost burden for the healthcare system as a whole. Let's now transition a little bit. There have been treatment advances in the past few decades, namely in the past 20 years. However, even with monoclonal antibody, commonly referred to as biologic treatment for severe asthma, up to 60% of those patients are either suboptimally controlled or not controlled. We know what suboptimal or uncontrolled therapy can lead to. And we're here today to learn about a molecule that studies have shown is involved with asthma pathogenesis. That molecule is thymic stromal lymphopoietin alpha, or TSLP. So let's discuss the role of TSLP and how its role in asthma pathogenesis stems from the epithelium. TSLP is one of the cytokine molecules called an alarmin. Alarmins include 2 of the interleukins, interleukin 25 and 33, and TSLP. All of these alarmins, namely TSLP, have been found to play a role in asthma pathophysiology. TSLP, through multiple mechanisms and endotypes that we will review, is at the very top of the cascade, controlling innate immune system processes,